I invite our next keynote speaker, Dr. David Friedman. Dr. David, you are there?
Yeah, I'm here. I'm just trying to share my screen. Let me just get it up.
Yeah. Dr. David is an authority in, he has done a lot of work in angle closure glaucoma. So it's our pleasure to have Dr. David over here, and he's going to talk on angle closure glaucoma, newer paradigms for treatment. Over to you, Dr. David.
All right, thank you very much. I'm just going to briefly outline some important recent findings. I have no disclosure specifically related to this talk. Glaucoma, worldwide affects a very large number of people. But if you look at glaucoma blindness, angle closure is almost half of it. And that's because angle closure glaucoma is more frequently blinding. A lot of this resides in Asia, and the Indian subcontinent has a pretty high rate. If you look at blindness rates from angle closure glaucoma, in population-based research, they're very consistently higher than in open angle glaucoma. So it certainly is a more worrisome condition, typically because pressures run higher. It's interesting to look at the reported rates in Indians. It's somewhere around 1%. Myanmar actually has very, very high rates, and you may occasionally see patients from there. Angle closure terminology is just for the purposes of this talk so that everybody can understand who the study populations are that we're discussing. We came up with this definition, which is used by the World Glaucoma Association. Primary angle closure suspects are people who just don't have any disease, but they have no visible posterior trabecular meshwork for typically 180 degrees. And the pressure is in the 95th percentile for the population. There's no disc or field damage. So these are patients who were completely normal, their pressure is normal, their nerves normal. You see them, you do gonioscopy, and their angles look somewhat closed. That's who they are. On the left, you have an open angle. On the right, you have a suspect, no disc damage. There is a group that might have a very similar amount of contact with the iris and trabecular meshwork, but there's evidence that there's something else going on. We call this primary angle closure. They don't have glaucoma, they don't have damage. And the secondary effects are the presence of synechia or elevated eye pressure. I often really try to teach that we need to think outside of eye pressure as a defining term for glaucoma, because eye pressure is not the only thing that people can have glaucoma at any eye pressure, and a number of 21 is not magical. But in this case, if we look at people with narrow angles and we look at a high eye pressure, the likelihood those two things are independent is very low. So in general, we would say that this is associated, and the elevation in pressure may be caused by the iridotic trabecular contact. Then there's glaucoma, which is primary angle closure glaucoma. And then there's this acute angle closure crisis. And the reason we don't call it acute angle closure glaucoma is some of these people will do just fine after the acute attack. The lens is an important component of angle closure. We published back in 2003, angles and open angles open up. Even angles that have what we would consider plateau configuration, where the ciliary body is very pushing up against the iris, even in those cases, removal of the lens can open the angle quite a bit. What about the management of acute angle closure attacks? So first thing to say is, when I first was a trainee at Wills Eye, we saw a bilateral case of acute angle closure, and everybody was wondering what was so weird about this case. How could this happen? Do they have some syndrome? It turns out that if you register all cases, about 10% present bilaterally. We just don't see that many cases, so we don't always know that. About 50% will have an attack in the other eye if it's left untreated, and it can happen within hours or days. So what I recommend to our residents and to everyone is to do the iridotomy in the fellow eye on the day that you're seeing them with the presentation. Try to do it immediately. Obviously, patients may be anxious and may not want it done, but they really need it done. And so it's our job as clinicians to explain that to them. There are other publications on how to break acute attacks. One from Hong Kong looked at acute gonioplasty, so just basically laser into the peripheral angle, and that does drop the pressure quite a bit. One can do paracentesis. There's always a small risk dropping the pressure so suddenly, and so I typically will not do this unless there's a prolonged attack and really cannot break it with medications. And then there was this important publication way back in 2002 showing that if you took out the lens after an acute attack, as opposed to just doing an iridectomy, and this wasn't iridectomy, this was Germany and they were doing iridectomies, you had a much lower rate of requiring additional eye pressure lowering surgery. So taking out the lens in this case series, in this early trial, seemed to be very beneficial. This was followed up by a Hong Kong group trial, and you can see here that they used a failure of IOP greater than 21 off medications. Again, not really logical, and I want to emphasize 21 is not magical, but a lot of studies will use this cutoff. And in the phaco group, which you can see on the top, almost nobody required any additional treatment after having the lens removed, whereas in the iridotomy group, a very large proportion did. And that's an incredibly high hazard ratio. You were 14 times as likely to need some sort of treatment to keep your pressure under control. And if you presented with a very high eye pressure, you were even 4 times more likely. This was reproduced in Singapore. You can see this curve, it's almost identical, slightly lower hazard ratio, but clearly when you take out the lens after an acute attack, almost nobody goes on to have pressure control issues. And so I think this is one of the really important findings in the last decade, which is if a patient has an acute attack, they should be scheduled for cataract surgery sometime, 6, 8 weeks later. And that should be planned even if they're doing fine, because you're helping to prevent later pressure control issues. And a lot of people develop cataract after an acute attack. This just looks at chronic angle closure and lens removal. So these are people who have no change after lens removal, but this person went from a preoperative pressure of 20 to a postoperative pressure of around 12. And you can see most of the pressures went down after this procedure. So this led Augusto Azuara Blanco in Ireland to propose a pretty large, important clinical trial, which was published in the Lancet, and I think should influence how we think about treating these patients. People were enrolled if they had primary angle closure, so no evidence of disc or field damage, with very high eye pressures, 30 or higher, greater than 30, or if they had primary angle closure glaucoma, and they did have to have elevated pressure as well. And they either had lens removal or iridotomy. They were followed for 3 years. These were people with clear lenses, clearish, not necessarily totally clear, but not cataractus. And this just goes over what I just said. They had to have angle closure. They were all newly diagnosed. They were all over 50. They had to be over 50 because you didn't want to make people suddenly presbyopic. And they didn't want bizarre nanophthalmos, weird cases. They had 3 main outcomes in the EAGLE trial. They wanted to look at how people reported their own status, and that's called the EQ5D. And I put here the dimensions that are asked on the EQ5D. Can you move around? Can you take care of yourself? And this is done at 3 levels: no problems, some problems, or extreme problems. It's a very simple questionnaire, 5 questions, no, some, a lot of problems. And they also looked at pressure and monetary issues. The sites were distributed mostly in the UK, but also in Asia. And most of these were European-derived white individuals, although a third or so were Chinese. And most had angle closure glaucoma. The mean eye pressure at baseline was almost 30. This just shows that the EQ5D in the lens extraction group stayed the same. It started at 0.87 and ended at 0.87, but in the iridotomy group, over the 3 years, the EQ5D got worse, and this was statistically significant. So overall, EQ5D, general self-report of health, quality of life, was better at 3 years in the treated arm. So that's a big finding. That's very hard to show with an eye intervention. They also found that people who had their lenses out had a lower mean pressure than people who didn't. And if you look at medications, Just taking out the lens in people who averaged almost 30 millimeters of mercury, almost 2/3 didn't need any medications at all to maintain their pressure. Whereas in the iridotomy group, only about 1 in 5 were in this range, and many were on 2 or 3 medications. Also in the iridotomy group, a bunch of people ended up getting their lenses out, partially because we knew that this was an effective treatment at that point, and also had trabeculectomies and other surgeries. In terms of major vision loss, irreversible vision loss, it was greater in the iridotomy eyes, and that may be because you waited longer and then had to do bigger glaucoma operations. But overall, we do worry that cataract surgery can have endophthalmitis, CME, retinal detachments, so it's not without risk. In conclusion, from EAGLE, taking out the lens is associated with better clinical and patient-reported outcomes. It's likely to be cost-effective, but there are risks, and you need to have an individualized discussion. For me, I often offer an iridotomy. 1 out of 5 people were well controlled with just the iridotomy on no meds. So it seems reasonable to try that. And then we can discuss whether they want to move to lens extraction or other treatments. What about those without angle closure disease? They just are suspects. If you look at China, India is going to have a lot more old people. The growth in the aged in the world is enormous. Over 640 million people over the age of 50 by 2050 in China. What do you do with all the PACS? We have a great study from Chennai. This shows you, this is a really important slide. This shows you what it really is like in the angle closure world in a steady state. They went out, they looked, they found everybody, and this is what they found. There were almost 300 suspects, almost 100 who had PAC, and only 34 with glaucoma. So among all the people we see with angle closure, less than 10% have a disease, have glaucoma. So that is what happens when people live and die and go through the life cycle. This is where we end up. So a lot of people who are in that suspect group will never go on to disease. We had looked at the natural history after iridotomy in patients who'd had an acute attack. These patients had a mean deviation of about 11 decibels on visual field, and about 10% of attack eyes were blind from glaucoma. The fellow eye did very well. Almost none of them developed clear, definite glaucoma. And so those eyes that had an iridotomy that were fellow eyes did really, really well. So it seems really important to avoid acute attacks, and that would be one argument for iridotomies. The fellow eyes do well. So should we be doing iridotomies in everyone? Iridotomies have the potential to break the blood aqueous barrier. You can have acute pressure rises. Clearly, there's some glare and diplopia caused by it. And we had questions about cataract or endothelial cell loss. So we did the ZAP trial, the Zhongshan Angle Closure Prevention Trial, which was recently published in Lancet. It was in Guangzhou in southern China. And this was a population-based screening of 10,000 people to find about 900 with angle closure and no disease. And we followed them for 6 years. The endpoint of that study was a composite. It means that if any of these happened, a patient reached endpoint, pressure above 24 and 2 or more visits, synechia or acute angle closure. And this is the bottom line of that study. Iridotomy reduced endpoints, but rates were very low. In an untreated eye, there was a risk of 1 event in every 125 years. You could reduce that risk with an iridotomy almost in half, but that was the risk. And if you look at this, it's almost all synechia. There are very few elevations of eye pressure, and they're similar between the 2 arms. And there are very few acute attacks, and I'll talk about that in a minute. In terms of acute attacks, 3 control eyes and 1 LPI treated eye had acute attacks after they were dilated. We dilated people to look for cataract development because we were worried that that could be a side effect of iridotomy. And so we caused some attacks. That means that in the control eyes, there were 6 cases in 10,000 dilations. And that tells me that it's still pretty uncommon after dilation to get an acute attack. Go ahead and dilate if there's an urgent need. Only 2 attacks occurred outside of dilation in the control eyes. And that means that there was really about 1 in 2,000 eye years acute attacks. Pretty rare. There were really no serious side effects. So our overall conclusions were that LPI was protective, but mainly against PAS. Most cases of acute attacks occurred after dilation, pretty rare otherwise, and therefore we may be doing too many iridotomies. This is the team, that's Heming Guang, that's Guangzhou, that's Paul Foster and Tin Ong and Ming and myself and the whole team that did this work. Overall, I want to leave you with the major things I think you should think about in your practice. Acute attack eyes should have lenses removed after the attack, sometime a month to 2 months later. Iridotomy in the fellow eye. Eagle should change the way you think about angle closure glaucoma. You should be considering cataract surgery earlier. And ZAP shows that maybe we don't need to do iridotomies on everyone. Thank you very much.
Thank you, Dr. David, for such an elaborate talk of a keynote address. Regarding one last point, what you mentioned, I would like to have Dr. L. Vijaya's views on removing of lens in case of acute angle closure attack. Just to give a take-home message, because we as GSR members really don't advocate, and Dr. David has raised up this point. So just one short comment, madam, so that we can have a take-home message for all our members who are viewing this.
David always stirs a lot of debate whenever he talks about India. I still remember maybe a year back what happened. I mean, that study did show that having worked in Chinese eyes for a couple of years, I mean, the kind of acute attacks, what you see there, you hardly see them in India. I think those eyes, definitely, unless you take out the lens, they don't do well. And it is a struggle to do the PA and control them. So I'm not sure whether we can go ahead and remove the lens when there is no cataract in Indians, because I haven't not done that in India. That's all I can say.
What about after an acute attack? What about
yeah, I'm talking about the acute attack. I'm talking about the acute attack.
Even after an acute attack?
Yes.
Okay.
So we do have a good.
Do that study. That's an easy study. That's an easy study to do.
We don't see so many acute attacks here. So we don't see not as common as what we at least I have seen in Singapore.
Yeah, very common in Singapore.
Thank you, ma'am, for this.